second talk in the secondary analysis of existing data seminar series. I'm going to start off with a few slides, just giving an overview of the series and an overview of the biostats, epidemiology, and research design core that is presenting this series. We're part of the Center for Clinical and Translational Sciences. All right. So first off, the goals of the secondary data analysis seminar series are to educate investigators about existing data and how that data can be used for research, to partner with investigators interested in performing secondary data analysis and assist them in developing successful research proposals. And finally, to increase awareness and visibility of CCTS, BIRD members, and resources. The seminars are the third Thursday of every month from 12 to 1 p.m. So we had our first talk last month on the Women's Health Initiative. That was pretty successful. Today's talk is about CMS, the Center for Medicare and Medicaid Services. Both talks are being recorded and will be posted to our webpage, the BIRD webpage on the CCTS. So they'll be available for follow-up. Future talks include the National COVID Cohort Collaborative, PCORDNet, a couple of data archives from the NIH, and Partners for Kids, which is going to be in August. And of course, if we have continued success with this, we'll add to this, and we'll continue to present new data sets as we move forward. All right, so a brief overview of the biostats, epidemiology, and research design core of the CCTS. So our mission is to ensure that research conducted under the construct of the CCTS is based on sound and appropriate statistical design and principles. So first, to collaborate with CCTS investigators at both Ohio State University and Nationwide Children's Hospital in all aspects of quantitative translational research, including design, reproducibility, and scientific rigor, and statistical analysis. Train investigators on research design, reproducibility, and biostatistics as they relate to clinical and translational research. And identify innovative and effective statistical methods in response to specific project needs that enhance the quality of design, interpretation, and communication of results. We like to say that the BIRD core has a proven recipe for success, including rigor in study design and analysis, expertise across a broad spectrum of biostatistics and epidemiology, established collaborations with multiple investigators, innovative work in biostatistical methods, productivity in grant submissions and publications, and many years of experience on NIH and other funded grants. There are multiple ways we can help investigators. It starts from the genesis and formulation of research hypotheses to the design of the study, and finally statistical analyses and modeling. Here is a summary of the BIRD core members. I won't go through them all, but we do have a mix of both faculty, staff, biostatisticians, and epidemiologists across College of Medicine, College of Public Health, with a variety of expertise. And with that, I'm going to hand it over, stop share. So Wendy, you're free to take the helm.
Thank you, Guy. Guy, when I start to share my screen, I think the system will actually block you from sharing screen. Is that okay?
Oh yes, perfectly fine. I'm done.
Hello, everyone. I'm glad I see now 43 people logging in. So I think we have a really good number today. And thank you, Guy, and thank you CCTS and BIRD for inviting me to talk about the data resources from the Centers for Medicare and Medicaid Services. Just a quick introduction about myself. My name is Wendy Xu. I am an associate professor in the Division of Health Services Management and Policy in the College of Public Health. And I've scrolled down the participants list and I see a number of you are my familiar friends, and I'm glad to see you all again. So I think, okay, let me see. So you will be able to see my screen, right? Guy, could you nod or give me a sign?
Yep, I can see it. Looks great.
Great. Yeah, thanks. So in recent years, like you've seen CMS and with all kinds of healthcare reform and different payment structures and a lot of advocacies. You've seen the name of CMS show up in newspapers a lot. There is a big reason for that, and I think within the context of data for research, I would like to open my seminar with a brief introduction and a walkthrough of the Medicare and the Medicaid programs. I think that will help us have a better understanding with what type of data are going to be available and why they're made to public for research and why there are limitations within those data. So currently in the US, the public spending for healthcare accounts for about 45%, and the other 55% comes from private sources, such as like your employer-sponsored insurance or when you pay out of pocket. So within that 45% of public spending, majority of them are tax dollars paid through the CMS programs, the Medicare and the Medicaid. So they are currently, the CMS as a whole currently is the largest government source of healthcare funding. So that tells you the background of you would anticipate under the CMS programs, millions of lives in the US are covered through those programs, and they do generate a lot of data. The CMS gathers and carefully formats data to support the agency's operations. So that's why those data started to accumulate and sit there. So that's the purpose of why CMS gathers data, is that they gather the data originally not really for us to do research. So we use this, what we call as a secondary data for research. This allows for retrospective research studies to happen using those secondary data. So research is a very nice byproduct as a result of government functions in the insurance program field. But we also have to work with certain data limitations, which I will talk about very soon. Okay, so just another quick overview. Both Medicare and Medicaid programs were established in 1965. So as a result, part of the public data existed since then, such as the National Healthcare Spending Account, which sometimes are used for research. That was the time when taxpayers were added into the equation of funding healthcare in a more prominent way. Majority of the part of the CMS programs are from the tax dollars. And a little bit of them comes from enrollees premiums in general. Okay, now let's talk about Medicare. Oh, I'm sorry. So that's part of my slides were something. Okay, what happened with my slide? Okay, so let's share the screen this way. Okay, I'm sorry, I accidentally probably put the slide that I recorded for something. Okay, here we go. So now, are you able to see this type of slide in my screen? Okay, we can use this one. Okay, now let's talk about Medicare program first. I love talking about Medicare program in all kinds of my class. I teach US healthcare system, and I also teach health economics in college public health. Medicare is a very typical entitlement program. Regardless of your income level, most of people will be eligible for Medicare by the age of 65. So currently the age-based eligibility enrollees account for about 85% in the Medicare program. So they are very often your study denominators for research. And there is also about a 15% portion in Medicare program consisting of enrollees entitled for Medicare because of the disability. So you sometimes see children or people with like blindness, like people who are born or later become blind to be in the program. And the third largest population in Medicare are enrollees who had end-stage renal disease. So they are also entitled to become a Medicare enrollees. So on the right-hand side, I've shown the characteristics overall of Medicare population. Apparently, even without comparison, intuitively, we can tell Medicare beneficiaries tend to be much sicker, with a lot of function limitations. And at least 1 in 5 of them have several chronic conditions combined, and many of them also have behavioral disorders. And you got a very big portion of Medicare beneficiaries who are older than 85 years of age. So that enabled many of the studies that focused on the very elderly population in the society. And you may wonder, like, why there are only about 3%-ish of Medicare enrollees in a long-term care facility. That is because Medicare is designed not to pay for long-term care overall. It pays a little bit of nursing facility, but overall, Medicare doesn't pay for those. So those are the, you can expect a lot of the, like, in the sense of denominator of the study population to begin with in order to select study samples. And because of the nature of aging and because of the numbers of Medicare enrollees, you could have a lot of leverage of studying a number of relatively rare conditions whenever the sample size is large enough. So it offers tons of research opportunities. Okay, a bit more about the structure of Medicare program. As typical in any other parts of the US healthcare system, the Medicare program is incredibly complicated for anybody. And I'm sure many of you have signed up for parents or even grandparents when they become Medicare eligible, and to help them selecting plans and how to enroll and what portion to enroll. And that is a typical situation faced by most of the elderlies in the US when they are eligible by age. There are 4 parts of Medicare programs, and they each cover things in somehow different ways and different portion of services. Medicare Part A covers inpatient hospital stays, skilled nursing facility. Note that is only skilled nursing facility. The long-term care, the custodial care, or day-to-day 24-hour home health care, just like for meals, for most of the time, if you only need people to check in, a lot of things in long-term care situation are not covered. So they do cover some home health visits for routine healthcare. And Medicare Part A also covers any services happen in a hospice healthcare setting. Part B would cover physician visits, outpatient services, emergency room use, durable medical equipment such as like oxygen tanks, wheelchairs, preventive checkups, and also some home health care visits. That is under the Part B. We call Part B medical coverage versus Part A like hospital coverage. We typically refer Part A and Part B combined as the traditional Medicare fee-for-service program. So you might have often encounter literature that say we use Medicare fee-for-service data for our study. So those refer to usually Medicare Part A and Part B combined, because most, like over 95% of Medicare fee-for-service enrollees have both Part A and Part B. And in fact, you have to decide to sign up by the time you're eligible. Otherwise, you're facing the penalty without signing up for those. And the Part C refers to, it was the original name since the 80s, but under the George W. Bush administration, the name was changed to be Medicare Advantage Program. That is a very unique US type of arrangements where beneficiaries can enroll in a private health plan, but receive all Medicare covered Part A and the Part B services. In other words, you either choose to enroll in the MA plan that takes care of your Medicare hospital and other routine healthcare services, or you stay within Medicare fee-for-service program. And there is a very fast increasing enrollment in the Medicare, the Advantage program. We call that MA program. Currently, MA program provides health coverage for about 40% Medicare beneficiaries. In some states, this proportion is even higher, but in some states, it is lower. It depends on the penetrations of MA program. Because the MA program are run by insurance companies, private insurance companies. So some of the large players you've seen in the market are like United certainly is a player. And you see those Aetna, Cigna insurance plans all over in the Medicare program. So part of that, and in order to protect the privacy and commercial secrets of private plans, sometimes in research, you will not be able to examine price of services for this Medicare Advantage population. The CMS does make the MA data available for research very recently, but they strip out all the prices information and also strip out certain type of provider information to protect the commercial secrets. So again, that's why you see most of the research were done using Medicare fee-for-service claims. But I would keep in mind that there is a decreasing proportion of beneficiaries covered in the Medicare fee-for-service program, which is a limitation. But that program as a whole still is very representative of Medicare population as a whole, and still provides very valid and rich information for research. And lastly, the last part of Medicare program is the Part D, which is a prescription drug program. Again, the Part D programs runs through private plans that contract with Medicare. But differently is the real spending for drugs are available in the Part D claims. So you do get the real claims in the Part D portion of fee-for-service population and the MA Medicare population. But one limitation, and I know especially this can be a limitation for provider, is many of you may be interested in looking at what drugs are prescribed. But because of the data, the way CMS gathers data is through their warehouse of when they reimburse providers or reimburse pharmacies or pharmaceutical companies. They only collect and be able to collect the prescription drugs that are actually filled by beneficiaries. So I want to make that distinction clear. And similarly, because those data are retained by CMS for their operational purposes, and CMS is a large, very, you can imagine similar to a national insurance program as a large company. So they only return those data when the transactions happen. If a physician ordered, let's say, a mammogram, but the patients never went to obtain the mammogram through Medicare program, you will not be able to see any of those data represented in those, especially in those claims data. So here, it shows you, you don't have to look at this chart like line by line, but by looking at the overall colors, only looking at this bar on the far left, you'll see mainly like about 78 to 79% of Medicare spending come from either general tax revenue or our payroll taxes. So it's predominantly funded by tax. And that is related to the data privacy levels of CMS. You probably have heard that CMS has been very difficult in approving certain type of data. There's a reason why, because they have to be really responsible for Medicare and Medicaid beneficiaries and protect their information, and they have to be responsible for taxpayers' dollars without easily releasing the data for any other purposes. Okay, now let's talk about the Medicaid program. Medicaid is also an entitled program. But different from Medicare is Medicaid is a program which represents a partnership between federal government and the state government. Federal and government and states co-fund Medicaid programs in each state. In some states, the rule of thumb is with states with a higher proportion of lower income population, they would get a higher proportion of federal dollars to subsidize their costs for Medicaid program. So the federal dollars are not distributed equally across states. It's based on the state's financial situation. This is an entitlement program primarily designed for lower income population before the Medicare eligibility age. So you see adults ranging from age 19 to 64 with incomes nowadays with income below 138% federal poverty line enrolled in Medicaid. And I'll talk about a little bit complexity between states as well. Currently, those adults represent about over 30% of Medicaid population. And another 43% of the population in Medicaid programs are children from lower income families who enrolled in those insurance programs for children governed and run by Medicaid agencies. And you do have 14% of the population on average within Medicaid who are disabled. Though this disabled population are heavily overlapped with the disabled population in Medicare. So it's a chicken egg thing. The loss of capability to work result in lower income. And lower income sometimes is related to worse health outcomes and potentially could lead to disabilities, and then they are eligible and entitled for Medicare. So that is a heavily overlapped population with Medicare. And another overlapping population with Medicare is well, for a lot of aging populations also have low income. So their primary payer is Medicare, but they're dual eligible for Medicaid program. Medicaid program helps to pay for Medicare beneficiaries, only low income Medicare beneficiaries, premiums to Medicare and cost sharing. So for a proportion of those population in Medicaid, you may be able to request data from CMS to study them because they are both in Medicare claims and Medicaid claims. In other words, when you request data from Medicare, very often the data for a proportion of people covered in Medicaid program will come with Medicare data, and vice versa. Okay. So for Medicaid benefits and spending, a very large part of Medicaid benefits are paid towards long-term care in nursing homes. So that's the part Medicare does not cover. And we also hear a lot of anecdotal stories of elderly or people with the needs of long-term care will spend down their money or transfer their savings to children and others in order to be eligible for Medicaid. So Medicaid started to pay for long-term care. So that is a part of the situation. And the other part are like in the very older, among the very older senior population who spend a very long time in long-term care. Eventually, everyone would eventually be able to be eligible for Medicaid paid nursing home after spending a portion of their fortune by themselves. And then for like adults and children, Medicaid also covered routine healthcare, and some states have the flexibilities for enhanced benefits. And another key function of Medicaid programs in each state is to support the local healthcare system and provide funding for safety net clinics and hospitals. So that is a key role. And they also, as I just mentioned, assist spending for Medicare beneficiaries. So here is a chart that summarizes what type of services could have been covered by Medicaid. So as you can tell, HIV/AIDS services are also covered as a big component of Medicaid program because of certain federal laws that passed earlier that specifically designated the role of Medicaid to help pay for those programs. And Medicaid also provides lots of support for children with disabilities or children who continuously need, and especially those who are bound at home. Like through Katie Beckett program, the Medicaid funds a lot of regular home healthcare services for children who are dependable on technologies to sustain their life or who have permanent illness, regardless of their family income. And a lot of pregnant women with low incomes rely on Medicaid programs for their prenatal care and delivery costs and a period of time after postpartum. So those are the services provided in Medicaid. And again, thinking about denominators and numerators of research questions, the Medicaid denominator would be very different than Medicare, apparently. Medicaid denominators would have much lower income levels, typically on average younger than Medicare, but they also have a variety of chronic conditions, although not necessarily related to age-based conditions. There are tons of behavioral conditions that can be examined using the Medicaid data for this population. And also, please feel free to stop me for questions throughout the way. I kind of feel it will be nice if we run this seminar as conversational as we can, but I also will leave some room by the end for questions if that is what you prefer. Okay. Oh, I have a typo here. I'm sorry. I meant to say Medicaid coverage. Oh, actually, the fact that I couldn't really share a screen, like run the slide, it provides me with some leverage. Okay, I see there is a question. Okay, one of you asked, do these data represent the amount billed, amount paid, or both? Interesting question, depending on the programs. When we talk about CMS data, we often think about them as a whole, but apparently they're actually not a one whole thing. As I said, like for Medicare fee-for-service, that is a government, government dictate the fee and the reimbursements to providers. There's no such a thing as like a charge. They have to take the fees from government. So as a result, you see in Medicare fee-for-service claims, those are the actual reimbursements. And similarly for Medicaid fee-for-service. For Medicare MA plans and also a lot of Medicaid matched care plans run in each state, well, they are capitated payments. So CMS does know the exact payments and billing amounts paid to insurance plans, but they do not necessarily release those information to researchers all the time. It's more of a case by case. I hope that answers the question. And I do want to show that just for knowledge-wise, here is a chart that compares the enrollment distribution in Medicaid program versus where the spending happens. As you can tell, like children or younger adults account for a very large proportion of Medicaid program, but majority of the dollars in Medicaid programs are going towards persons with disabilities and elderly population who also have Medicaid coverage. And lastly, there is a complication in Medicaid data versus Medicare. Well, as part of the Affordable Care Act, many states have chosen to expand Medicaid coverage to low-income, childless adults in their states. But currently, there are 16 states that didn't. So So when you request data from CMS, you would need to be mindful of which states you're going to pick from. For example, if you pick Texas, although it is a state with a lot of population, but you do not necessarily are able to get the population who would have been eligible as in New Mexico. Like New Mexico expanded Medicaid to younger adults without children. So you will be able to get the population represented in that state's Medicaid data. But because Texas didn't expand that type of coverage, when you request data from Texas, it means large by large, you're getting data from the pregnant women, the children who are in lower income families. You got the data of disabled adults, and you got the data of Medicare beneficiaries who have low income and supported by Medicaid programs. So that does impact your denominator, and depending on the research question, I think people need to be mindful with from where you request the data. Okay, so Medicare and Medicaid programs apparently generate a lot of data. And through so far, when I was walking through the slides, I only mentioned like a portion, probably even a smaller portion of the data they generate. And I see another question coming up. Okay, thank you, Chris. So, well, those program generate, first of all, it generates data like covers a variety of topics. Those are just majority of the topics I can think of, and the topics that some of them I've used in my own research. And I'm sure I didn't run a comprehensive list enough, but they're listed in the CMS website. So many of those data were used for enrollment and insurance plan training related research, because as part of the programs, state agencies and federal agencies do maintain very comprehensive and valid data about beneficiaries for enrollment. And of course, the spending, especially for the fee-for-service program. And those all kinds of transactions among patients and providers, and between providers and CMS, generates a lot of claims data in both fee-for-service part and in managed care. And because of the private use in Medicare claims data, I'm going to talk about that in more detail very soon in the next couple of slides. In the CMS, again, as part of their efforts to operate those programs and for their continuously efforts for quality improvement within their agencies, they run a lot of surveys to collect patients' experiences. And they also recommended hospitals and different organizations to report quality data. As a result of those mandatory reporting process, CMS also made public available a lot of those quality related and outcomes and survey satisfaction related data that can be used for research. And for part of their data, the death date comes with the data as well. Okay, if you wonder where you can go to look for all types of data, they have probably like over 100 different data sources over there. So there are two, actually, let me put them in chart. Okay, because you are not able to have access to my slides. Okay. So those are honestly the websites I constantly check by myself. One is the second listed in the second line are the CMS official website that lists all types of data, reports, and statistics. I use them very often. And the other one is ResDex data. ResDex website. ResDex is housed in University of Minnesota. They are a third-party data vendor that is devoted to serve CMS. So they are the data agencies. You submit all those requests and data process requests and variety of different things, and they also send you the data. So that is the warehouse, and they have a lot of very useful knowledge-based articles. And I used to be a student in University of Minnesota, where I myself learned tons of things from their articles as well. And I also borrowed some of their information through their training programs. Okay, now I would like to talk about 3 different privacy levels of CMS data. That matters a lot for research process, and I'll explain why. First of all, there is the research identifiable data. Researchers commonly refer them as the RIFs. So sometimes when you like correspond with those data agencies and they say, do you need RIF data or LDS data? That is what it means. The PHI information and PII, those patient protected individual information, are included in those research identifiable data files. Those information are such as like you do get the residency zip code. Like in most cases, depending on the data sources, the real provider NPIs, and the patient birth date and death date, depending on the file. And the reason why those become part of reason, like you got the birth date and I got the zip code, and part of the reason why they're so protected was because as part of their claims transactions, providers are required to document diagnosis and procedures. So just imagine you're a provider who typically treat more rare conditions, and you do know what diagnosis and procedure code you have provided only twice in the past 3 months, in the first 3 months in 2020. And you are able to get from the data about the patient's zip code. So there is a small chance for certain diseases in certain population to be identified. So as a result, a CMS automatically strip up all data cells if that is below, I believe, 11 persons in any of those combination of data cells. And you cannot possibly report them in any type of research. Those RIF data can be very expensive. So they are the most expensive CMS data files. And the second privacy level is the limited data set files, the LDS. It depends on what program of data you like to use for research, and depending on what you actually need for research. In variety of data files, the LDS and the RIFs are almost identical and extremely similar, although you will not get the PHI and the PII data from the LDS. For example, they have both RF version of Medicare claims and the LDS version of Medicare claims. But in the LDS, you still get individual level diagnosis, procedures, service dates, and all tons of clinical information, but you won't get the direct HIPAA identifiers. So that is how they maintain the data in the LDS version. And you see some very useful and widely used surveys, such as Medicare Current Beneficiary Survey is operated as the LDS level. Because the survey itself does not contain diagnosis or procedures, although the survey would contain age and zip code information. So you can get part of the information depending on the research topics. And the next level is the public use files. I also use those from time to time in my own research. Those are non-identifiable data files anyone can download from CMS. Sometimes CMS will require like brief DUA for public data, but still then you'll be able to download it to your own use, your own data storage. There's no IRB approval needed for use of those type of data. And they are like a lot of those data files. For example, MCBS, the survey I just mentioned, Medicare Current Beneficiary Survey, runs a public use version of the survey without zip code and masks certain levels of nuances of race. And you also can get the Part D plan level prescription drug formulary data and the actual drug price at the plan level. And similarly, the MA plan level enrollment and beneficiary demographics are widely available as well. And for sometimes, if you just want to entertain yourself, learning about Medicare claims, CMS even post a public version synthetic Medicare claims data that looks exactly the same as the actual Medicare claims data for people to play with. And you've also got the hospital cost reports. That is a public information. And for people who are very interested in using data for a lot of other data run by other federal agencies that also cover those populations. For example, the Health and Retirement Study run by a National Institute of Aging. It is a public data source. And that is a longitudinal panel where you can track beneficiaries since age 50 for many years. And there is also the National Health Interview Survey run as part of the census effort, in the Medical Expenditure Panel Survey run by HRQ, and the CDC run the births data for a lot of preventive related surveillance. And I see there are some comments and questions. Let me see. And thank you, Chris, for putting other sources like, yeah, the enhanced data is a very useful information. And okay, so I have 20 minutes left. Sure, I think I can run faster, and I will save some questions by the end. Well, Medicaid data request process is a little bit more complicated. This is the website where to request from federal government about the national Medicaid data. But most of the Medicaid data can be obtained by from each state agency. So the GRC and medical center runs those data as well. And there is also the public version of certain Medicaid data. Okay. For the limited data sets and the research identifiable files, the reason why I put these slides up was they do need a formal DUA between the university and CMS. And the university level have to sign off, and it's not happening at medical center level. And they do need the IRB review, and typically they're not really exempted. At the minimum, you do need an expedited IRB review for LDS and RF data files. So I encourage you to explore those things through the ResDec website when you can. And I do want to mention the cost of data. Some of them can incur a pretty big cost. It depends on the version of data. Several factors will determine the cost. First is the number of beneficiaries you're requesting, which is one of the biggest determinants. And whether at what level you will ask a CMS to look for beneficiaries for you, at what type of complexity, and what type of files requested. Many of the data has the fee schedule based on each file each year. So the cost of data really need to be taken into consideration for research projects. Okay, now I would like to talk a bit about the Medicare administrative claims data, which is one of the most common data sources people use. So those data are derived from reimbursement and payment transactions. So you only got drugs or procedures that is paid to providers. So if it's not paid totally out of pocket, you don't capture any of those in claims data. But that being said, you do got a lot of useful information such as procedures performed, because providers have to collect payments for the procedures. You got who provided the services and what diagnosis codes were put in there to justify the procedure performance. And depending on the level of file, sometimes you also got the zip and county level area characteristics that you can also link to other types of data. And you, of course, you got the age, sex, race, and this type of demographics information as well. Okay, so the strengths are very apparent. You have a more convenient, large population sample that allows you to overcome the typical statistical power limitations found by clinical trials. And those data can be linked to cancer registries, such as in the case of SEER Medicare. Sometimes they can be linked to vital statistics. And sometimes they can be linked to surveys by Medicare or by the run by National Institute of Aging, or all kinds of other census data, as long as they're public information and the linkage is allowable. In the RB and in the request to CMS, typically you're required to indicate at what level and how you're going to link to other data sources. But the limitations are also very major. You're not able to capture disease stage and severity, unless in some of the cases when you're linked to cancer registries. So that is a major limitation in most of the cases. And you, of course, you cannot capture services not run transacted through the programs. Okay, now what type of questions could possibly be answered retrospectively using secondary data? Here are a couple of examples. And I actually will quickly show you the slides one by one. So some researchers have used the SEER registry linked to Medicare claims to answer questions like risk of pelvic fractures in older women following certain conditions. They would actually track women with cancer-related conditions and then see what happens after certain events. And they can track utilizations. They can also track pharmaceutical therapies, other procedures then. And in a lot of cases, you will see people track the hospital admissions, readmissions, and ED visits. So this is one of the examples how people approach the research topic. And this is one of the studies done by the Department of Surgery here at OSU. Among those, unfortunately, I only know Dr. Pollack. So like I listed here, and maybe some of the researchers in this study are actually in this talk. So that is another example. Researchers have used Medicare fee-for-service claims to examine multiple chronic condition-related healthcare use and outcomes post-procedures. So that is, in this study, they were specifically interested in looking at the prevalence of certain mental illnesses after certain surgical procedures and as indicators for certain outcomes. Okay, so this is one of my study where we use the drug claims to examine one of the federal policy that give drug discounts to safety net hospitals. So that was done by using Medicare fee-for-service claims data from Part A, Part B, and the Part D. So you'll see those secondary data used a lot in policy-related health services research in Medicare population. Okay, and this is the example also like one of my studies, which is an example of using survey data linked to Medicare claims. So this research used the Medicare current beneficiary survey linked to Medicare fee-for-service and linked to another public federal data resources to get a local characteristics. The strength of surveys allows you to engage the socioeconomic characteristics where you do not see from CMS transaction data. For claims data, CMS doesn't really, it's not their job to track people's income or education. But in the survey, when they survey a portion of Medicare population, they will collect a lot of detailed information about income, usual source of care, and education. So it becomes a strength when people link the survey to claims, but it also requires a lot of efforts to request the data and tell CMS why you're linking them together and justify the efforts. And sometimes it can be harder to reuse the data later on. And you might get the impression of a higher privacy level, like only RFF can produce the highest level outcome for research, which is actually not true and not necessary. I'm showing you this JAMA paper using the exact public data downloadable. Anyone can download it from Medicaid. That is quarterly Medicaid state drug utilization data. So researchers have used this data to examine changes in payments and the market share of insulins in the long-acting insulins in Medicaid population after approval of new products. And that data is very current, and it's updated every quarter. So people do track a lot of new information through that type of data. Okay, so here's my last slide. In summary, what type of data to use is dependent on multiple factors. The biggest factor is the research question. And the research question depends on what study population you're going to propose to use, and levels of detail needed to carry out the research question. And of course, the budget available and the time and energy to obtain the data files and the process of obtaining the data can be huge and tremendous. And also it depends on the storage capacity and your analytic capability to use some of those very large files. And lastly, so here's the advertisement for Guy and his team. They're terrific researchers. If you have questions, you should definitely contact them for help. And otherwise, if for any of the thing I covered today, feel free to email me about clarifications about my seminar, and I'm happy to answer any questions. Okay, I think we still have some minutes left. I'm open for questions. So you can, unless Guy still wants something to say.
No, thank you very much, Wendy. That was a great talk. And yeah, we do have some time for questions. So feel free to unmute yourself and ask some questions, or there's a few questions in the chat. Wendy, I don't know if you see that.
Oh, I probably didn't see all of them while I was
talking. No problem. One from Jennifer Cooper.
Okay, so what was the question? Oh, do you have experience using Medicaid just released? Actually, I haven't got a chance. The only time I've used Medicaid data was using Ohio Medicaid claims. That is a good data resource, but if you ask me whether I want to spend the effort to do that again, I probably will double think. Okay, so Jennifer, just to quickly answer your question, you should contact Dina Chisholm at OSU NCH. Dina uses a lot of Medicaid claims data for research, and she might know something about it. D-E-E-N-A, Dina Chisholm, C-H-I-L. Okay, oh my God.
Thanks, Wendy. This is Jennifer, thank you.
Yeah, sure, okay, you'll be able to search her.
Yeah, I do work closely with Dina, and she would be on the project that I briefly mentioned. So yeah, I was just curious if anyone else at the institution that you know of or that Guy knows of.
Yeah, ResTech will know. Thank you.
Yeah, they seem to be really useful, and Medicaid is certainly, or CMS is certainly advertising them to researchers and hope increase their use. And there's some really great online data quality tools available too. But just curious if anyone was already using them here.
Yeah, thanks. Other questions? Did I miss some? Oh, I see a question by Evelyn Arena. Is data available specific to hospital clinic? Well, it depends. For public available quality outcomes information, it is specific to each hospital system. For example, OSU Wexner Medical Center will generate one public quality record in CMS files. But for claims data, I believe you'll be able to identify every hospital that provides services to different clinics and like to different patients. Yeah. Any other questions?
What does the data only allow to look at the fee-for-service enrollees? How about the managed care enrollees? They could be very different in demographics.
Yes, that's a good point. So as I said in some of my earlier slides, it is tricky to request Medicare Advantage plan enrollees. Since 2019, CMS did start to release those data for research, but they withhold all the payment information. You do got procedure codes and diagnosis, and it's a separate request process. You have to tell CMS whether you want the fee-for-service claims and MA claims, and they also come at different price. So it's a very complicated request system. Any other questions?
Yeah, and this one, I put a couple of places where you could submit requests for help through my CCTS. There's a page you can go there, through our Center for Biostatistics project request form. There's a link there for that as well. I'll put it in the chat. Oh, Chris asked an excellent question. Mechanism to connect researchers with similar interests.
Is there a mechanism to connect this?
So there is, there's a way to, and I apologize that I'm kind of forgetting the actual software analytic tool that you can use to go and find folks with similar interests through Ohio State, through the CCTS. There is a way to do that. I will try Google it real quick. Although I you know, as a follow-up thing, we were thinking of, so we got everyone's emails for this, you know, having maybe getting a community going around different data sources that are of common interest for folks to follow up. We haven't set up anything yet, but you all are like free to follow up with me directly if you've got any ideas that you think would be useful and helpful ways to connect you with other investigators. I do think that is a great byproduct of this, and I would be happy to help facilitate that in any way. So feel free to contact me with ideas on that one.
Any other questions?
All right, well, thank you very much, Wendy.
Thank you.
Appreciate it very much. And let's, yeah, oh, I forgot one more thing, guys, before everyone signs up. I do have a link. Everyone can do it. There we go. Hold on one second. There is a red cap link for everyone, if you would be so kind and willing, for feedback. It helps us all, and she'll be helpful to Wendy to get some nice positive feedback. It's also helpful for us as we, you know, was our second talk in the series. So if you've got constructive comments about things, we're happy to take them and then you use that feedback moving forward. So thanks everyone for coming to the talk. Really appreciate it, and have a great rest of your Thursday.
Bye.